Good evening. I want to welcome everybody. I'm going to open up my chat here to this week's session, Happy Hour. We're pleased to have one of our associates at the lab, Dr. Nicole Bender, hosting tonight's session. Nicole is from Texas originally, did her undergraduate work at A&M University, and then went to medical school at UT Houston. Subsequently did a dermatology residency at the University of Wisconsin, Medical College of Wisconsin, rather, and then joined the faculty at the University of Florida, Gainesville. Was in charge of the inpatient dermatology consult service, and also actively engaged in resident education. Also completed a dermatopathology fellowship at University of Florida, Gainesville, and has been working with us at Sagis the last couple of years. Nicole's an excellent educator, and she is going to be speaking to us about cutaneous lymphomas. Before I turn over the floor to her, as always, if you have any questions, please feel free to post them in the chat, or you can email us directly at education@sagisdx.com, or you can email me, tdavis@sagisdx.com. So without any further hesitation, I'll go ahead and turn the floor over to Nicole. Nicole?
Thank you, Dr. Davis, for that introduction. I am going to be covering some cutaneous lymphomas, some common ones, today on this Happy Halloween. I hope you guys are all doing well. This can be sometimes a really scary or spooky subject for dermatologists and pathologists alike, but from a test-taking perspective, they're really quite straightforward. And that's largely because most of these entities cannot be tested on based on their identification alone from an H&E slide. They must provide some form of compelling clinical or immunophenotypic information to guide you to get this diagnosis. So you don't have to be the best diagnostician from a pathologic perspective when approaching test taking for cutaneous lymphomas. Instead, it's better to memorize some of the details related to it. So the immunophenotypes, knowing them very well, because that's how they're going to test you. They're going to give you some piece of clinical information. They'll show you the path, and then they'll ask you what the staining pattern should be. That's a much easier question to ask and get a correct answer from a dermatologist or pathologist than it is to ask you to identify a lymphoma based on an H&E slide alone. So that's kind of where I would recommend some of your efforts in studying those two. But let's see if I can share my screen. I want to do this one, share. Okay. Hopefully you guys can see this part of my screen. The first case I gave to you guys was actually just a reactive lymph node. So this is just to provide some kind of form of background so that we can jump off after we review some of the normal architecture of a lymph node. So we have fragments of lymphoid tissue, and within here we have these secondary follicles. So secondary follicles will have the center pale staining component surrounded by a darker rim. And in this lymph node, a lot of these follicles are expanded and even interconnected. So that's kind of what alerts you that this is more of a reactive phenomenon. But if we want to get on close and learn some of the architecture of the secondary follicle, let's do that. So this is a nice example of a secondary follicle. There is the cortex, which contains B cells. That's the germinal center and the margin and mantle zones. The germinal center is going to contain CD20 positive, BCL6 positive, CD10 positive, and BCL2 negative centroblasts and centrocytes. And then there'll also be background CD21 and 23 positive dendritic cell meshwork. The outer zone outside of this, the margin, then hugs the mantle zone. This is also still part of the cortex, and it contains those CD20 positive B cells, but these ones are going to be BCL2 positive and BCL6 negative. Outside of the cortex is the paracortex. This is where your CD3 positive T cells and that are also BCL2 positive hang out. So that's our cortex and paracortex for our secondary follicles. Some normal features of a germinal center. So germinal centers are going to exhibit what's called polarity. That means that part of the germinal center is going to be darker staining and another part is going to be paler staining, owing to the fact that centrocytes will accumulate in one area and centroblasts will accumulate in another. Other features of a germinal center are that germinal centers are highly proliferative, and so cells are turning over rapidly. There are errors that occur. So we're going to see a number of mitoses, and some of these cells will be programmed to die, and they'll form little debris that gets taken up by these macrophages. These are called tingible body macrophages. So these are large epithelioid cells containing little lymphocytic debris, and those are completely normal to see and reassuring to see in a secondary follicle, at least in the skin. So the next case example in the skin is this one. So we have this kind of large punch biopsy. We see a superficial and deep infiltrate of lymphoid cells. And some of these lymphoid cells are recapitulating that secondary follicle that we saw in the lymph node, but there's a lot of intermixed, kind of just patchy infiltrates of these small cells. So this is an example of cutaneous lymphoid hyperplasia, aka pseudolymphoma. These entities simulate lymphoma clinically and histopathologically, but they're considered benign reactive infiltrates in general. There are lots of different patterns of pseudolymphoma, but ideally you'll have a mixed infiltrate of inflammatory cells with reassuring architectural features and a negative T cell gene rearrangement receptor, or a negative immunoglobulin gene rearrangement study. So, of course, there are going to be false negatives and false positives, but overall the sensitivity and specificity of those assays is really quite good. So for this case, again, there are these areas that are recapitulating that normal follicular architecture with that central germinal center that's more paler staining with an outer mantle or marginal cell. There's a mixed population of B and T cells, and we should see other inflammatory cells scattered about. So in this one, we have a lot of these scattered eosinophils, actually. You see there's many scattered eosinophils. There's also scattered mature lymphocytes, and even maybe a neutrophil or two. So we've got some background normal inflammatory cells. We have our mixed B and T cell population. Our germinal center that we see looks normal, so there are scattered tingible body macrophages, again we see here. And there can be some scattered mitoses too, those are normal to see. And the mantle zone is in normal size and placement for this. So the immunophenotype for this is that everything stains accordingly, right? Germinal center cells are going to be CD20 positive, CD10 positive, BCL6 positive, and BCL2 negative. And there's going to be background CD21 and 23 dendritic cells. The germinal center is going to have a high proliferative rate, and there's going to be a prominent population of T cells, just background as well. So, and again, the T cell gene rearrangement study should be negative for this case, as well as immunoglobulin gene rearrangement study if you get that. So this is cutaneous lymphoid hyperplasia, aka pseudolymphoma. This next case is comparison. This one too, we have a superficial and deep infiltrate extending actually into the subcutis. There's prominent follicular architecture. These follicles, however, look a little bit different than what we just saw. So these have a much more prominent germinal center with a very thin to sometimes even absent mantle or marginal zone. So this one's putting those germinal centers on display. When we look at the germinal centers too, which are really extending into the subcutis, they are not normal. So there's no really appreciable polarity to this. All of the germinal center all appears to be the same color of cells. And when we get closer, we can see that tingible body macrophages are hard to come by. Here's one, maybe two. They're very rare and hard to come by. So that's abnormal. We shouldn't be seeing that. So this is instead what should be follicle center lymphoma. Follicle center lymphoma is a proliferation of the germinal center cells. So we know what the immunophenotype should be. It should be CD20 positive, BCL6 positive, BCL2 negative, and CD10 positive. This pattern that we see for follicle center lymphoma is the follicular pattern. This next case, here again we have a superficial and deep infiltrate of cells. This one now, it's more diffuse or sheet-like. There are some nodules of cells, and sometimes if you squint, you get kind of close, you can kind of see like, or I guess from far away, maybe you're trying to say that this is trying to look like a follicle, but really a lot of it is not. There's no architecture to it. It's just diffuse sheets of these lymphocytes. So there's no follicular structure for this one. So this is diffuse pattern follicle center lymphoma. Instead, now you're going to see these, or not instead, equally you're going to see sheets of small and medium-sized cells. Follicular structures can be observed focally, but then they kind of give you more of a poor sense of follicles. They would equally be atypical, as you see in follicle center lymphoma. There aren't great clues to the diagnosis of this. Really, the immunophenotype is going to guide you again. And so you kind of need that information to make this diagnosis. You should know that there's something wrong given the density and distribution of the lymphoid cells, but you need that immunophenotype. So sometimes a useful clue for this diagnosis is that normal reactive germinal centers are going to have a very high proliferative rate, so greater than 90% of the cells, versus in neoplastic follicle center lymphoma, the proliferative rate is much lower, somewhere like less than 50% for this. So follicle center lymphoma, neoplastic proliferation of germinal center cells, the growth pattern can be follicular, diffuse, or a mixture of the two. So that's that one. Next, we have another similar appearing infiltrate. We have this punch biopsy, again, of a superficial and deep infiltrate of cells that spares the epidermis. There's no particular architecture to this infiltrate, it's just spanning all of the dermis. When we go up close and take a look, the cells are markedly atypical. They are particularly large as well. So for me, when I'm trying to decide the size of these cells, it can be helpful to find normal cells that I'm comparing them to. So if we look at endothelial cells, a normal mature small lymphocyte will be about 1/3 to maybe half of an endothelial nuclei, but these cells are the same size, if not much larger than the cell of an endothelia. So these are very large cells that we see. The cells here are also very round or oval in shape. Large nuclei, they can have prominent nucleoli, sometimes multiple, or just single centrally located nucleoli as well. So this is an infiltrate made up of numerous centroblasts and immunoblasts, and this is diffuse large B-cell lymphoma leg type. This can mimic that diffuse pattern of follicle center lymphoma, but the single greatest criterion to differentiate diffuse large B-cell lymphoma from diffuse type follicle center lymphoma is BCL2 and MUM1. Follicle center lymphoma is BCL2 and MUM1 negative. MUM1 can be positive in some cells, which should be less than 30%. Diffuse large B-cell lymphoma is BCL2 and MUM1 positive. MUM1 should be seen in greater than 50% of the cells for diffuse large B-cell lymphoma. Otherwise, features can be that, again, diffuse large B-cell is made up of more of these large oval cells that look like centroblasts and immunoblasts, while follicle center lymphoma tends to have more of the centrocytes, those cleaved cells, and can have a greater proportion of the small mature lymphocytes mixed in. Mitoses for diffuse large B-cell lymphoma are usually frequent, and your general gestalt when you're looking at it is that this is malignant. I can tell this is something bad. I'm not sure what the cell of origin may be, but I need to stain it and see what it is because I know it's malignant. So this is diffuse large B-cell lymphoma. Sheets of cells spanning the dermis that are large, and then the immunophenotype tells you. Diffuse large B-cell lymphoma can develop de novo, or can be large cell transformation of another low-grade lymphoma. The cells are CD20 positive, BCL2 positive, MUM1 positive, and in at least 50% of the cells, CD10 negative, CD21 negative, and usually it's BCL6 positive, but it can be variable from that. The other differential diagnosis to consider with this entity is anaplastic large cell lymphoma, but that will be CD3 positive and CD20 negative. So that's an okay. Next case. Here we have another large punch biopsy. We have again, kind of nodular, patchy infiltrate of lymphoid cells, again, spanning from the superficial dermis all the way into the subcutis. We have some areas that are recapitulating those secondary follicles again, but compared to follicle center lymphoma, the germinal centers are much smaller. They're fewer, like farther in between, and the mantle or marginal zone is much larger, more prominent on these secondary follicles than we saw in follicle center lymphoma. But really the infiltrate is made up mostly of what's seen between the secondary follicles. So between the secondary follicles, there are these areas of more paler staining cells between the secondary follicles versus what we saw in, say, cutaneous lymphoid hyperplasia. You want to just kind of take a peek at that really fast again. The cells between were not pale. The cells between follicles were more hyperchromatic. They look like normal small lymphocytes, mature lymphocytes, nothing special. This one instead, the cells between are pale staining in comparison. They're larger. These cells are usually a little bit, they've got little notches in them. They're a little bit cleaved. And then you'll find normal, mature appearing reactive T lymphocytes scattered throughout. And a lot of the times you'll also find plasma cells scattered as well, mature plasma cells or plasmacytoid cells scattered, sometimes at the periphery, sometimes admixed throughout. So this is conventional marginal zone lymphoma. I know I just mentioned the small lymphocytes, but this marginal zone lymphoma can have a couple different variants to compare. I think I have a slide, yeah, a couple different variants. This example is a conventional type, which is the majority of cases, but there can be a lymphoplasmacytic variant, previously known as cutaneous lymphocytoma, plasmacytic variant, previously known as cutaneous plasmacytoma, blastoid variant, and cutaneous amyloidoma. This is a neoplastic proliferation of the cells in the marginal zone, so the immunophenotype is CD20 positive, BCL2 positive, BCL6 negative, CD5 negative, CD10 negative, cyclin D1 or BCL1 negative, and there should be a population of plasma cells, which are CD138 positive, that have a kappa lambda restriction, which is defined as having greater than 10 to 1 of the kappa to lambda or lambda to kappa. So the immunophenotype of marginal zone lymphoma is important to know. The light chain restriction, however, is the most important immunohistochemical feature for the diagnosis of marginal zone lymphoma. Of note, BCL6 and to a lesser extent CD10 can be useful to differentiate marginal zone from follicle center lymphoma, as those would be positive in follicle center lymphoma. Okay, next case. Okay, so here we just have one giant nodule of lymphoid cells in this shape biopsy. It's fairly well circumscribed. The cells themselves look actually small and relatively monomorphous. So when we compare them to endothelial cells, these cells are smaller, about half the size of endothelial cells. So we know that they're small. They just kind of look like normal lymphocytes, nothing special about them. So we need the immunophenotype in this instance. The infiltrate is going to be CD20 positive, CD5 positive, and CD23 positive. So this is an infiltrate of chronic lymphocytic leukemia. Patients with CLL can specifically have skin involvement, or their leukemia can be incidentally noted on biopsies for other reasons. It's really just recognizing this dense infiltrate of small, monomorphous, mature-looking lymphocytes that should alert you to this diagnosis. These cells are morphologically mature, but functionally incompetent. So they look like normal lymphocytes, they just don't behave like normal lymphocytes. So this is a CLL infiltrate. CLL is called SLL, small lymphocytic leukemia, when it's found in the lymph nodes and spleen. And it can have large cell transformation, which has a poor prognosis called Richter syndrome. And I know I already mentioned the immunophenotype, but it's CD20 positive, CD23 positive, CD5 positive, and CD43 positive, and cyclin D1 or BCL1 negative. Now, remember that CD3 positive T cells will also be CD5 positive and CD43 positive. These are aberrant in CD20 positive cells. So always compare your CD3 and CD20 positive cells when you're evaluating CD5 and 43, because it's normal to have CD3 positive cells with these markers, but abnormal to have CD20 exhibiting these markers. So good to compare them. Okay, this next case, we have another fairly nonspecific infiltrate of lymphocytes that goes from the superficial to kind of mid-deep dermis, and a somewhat band-like pattern up here, but then it extends along adnexal structures and vessels into the mid to deep dermis. These cells, let's take a look at them, are again similarly kind of small to medium in size, nondescript. They're have hyperchromatic nuclei. They have probably a little bit more pleomorphic nuclear features compared to the last case that we just looked at as well. There's no real architecture to this. So again, we kind of need a little bit of more IHC to guide us for this. I guess another thing just to point out is that the cells are restricted to the dermis, so there's no extension into the epidermis. This is just in the dermis, so no epidermotropism in this case. So the immunophenotype and molecular helps you for this. So staining for this case revealed that the cells are going to be CD3 positive, CD4 positive, CD5 positive, but they lost CD7. There's also a positive T cell gene rearrangement seen for this case. So you might be thinking I'm describing the immunophenotype of Mycosis fungoides, and you'd be correct. However, as noted previously, there is conspicuous absence of epidermotropism in this case. So the clinical helps with this case as well. This was a solitary plaque on the head and neck of an adult without a history of NF. So this is actually an example of cutaneous CD4 positive, small medium pleomorphic T cell lymphoproliferative disorder. These cells will also express a follicular helper T cell phenotype, which is PD1 positive, CXCL13 positive, and BCL6 positive in a proportion of the cells as well. There should also be a low proliferative rate for this infiltrate, less than 20%. And there should also be an admixture of CD20 positive B cells for this, but this is not a very specific architectural, doesn't have specific architectural features or even really immunophenotypic features in a lot of ways. The clinical help has to help guide you a lot in this, as it can be indistinguishable from Mycosis fungoides Sézary syndrome, and peripheral T-cell lymphoma, NOS. So you need a lot of information to get you to this diagnosis. Okay, next case. We have a bunch of fragments of a shave biopsy. Of this case, again, we have a very dense, diffuse, kind of nodular infiltrate of cells with conspicuous absence again of any involvement of the epidermis. So we've got a nice friend zone there. Let's take a look at these cells again. So these cells are really quite large. Don't have endothelial cells necessary. So look how large they are. Big cells, larger than our endothelial cells and even keratinocytes. So these are very large cells, really reminiscent of that diffuse large B-cell lymphoma that we looked at earlier, because these cells are large, they're abnormal, they've got irregular nuclear contours, they've got prominent nucleoli, there's frequent scattered mitoses all over. So this looks malignant again, right? So we have to use the immunophenotype to help us for this. There's no architecture that's helping us. We just have large malignant looking cells. So this immunophenotype is CD3 positive, CD20 negative, CD4 positive, CD8 negative, and CD30 positive. And CD30 is actually positive in more than 90% of the cells of this infiltrate. So this profile is consistent with CD30 positive lymphoproliferative disorder, which is an umbrella term containing 3 entities: anaplastic large cell lymphoma, lymphomatoid papulosis, and large cell transformation of mycosis fungoides. Given the size of this lesion and the degree of CD30 positivity, as well as the clinical presentation in this case, this biopsy represented anaplastic large cell lymphoma. There technically are no immunohistologic or morphologic features that can help you in distinguishing anaplastic large cell lymphoma from LYP. However, ALCL does require that at least 75% of the cells are CD30 immunoreactive, while LYP can have a much lower proportion of cells being CD30 positive, as well as even large cell transformation events can have very low CD30 positive, and that actually requires more of the number of large cells that you see. So ultimately, still clinical guides you in this diagnosis. That's anaplastic large cell lymphoma. So compare this to this. This case here, instead, we have a much smaller, daintier infiltrate of lymphocytes. This is more of a wedge-shaped infiltrate that we see. So we have more of a lichenoid band superficially that extends along adnexal structure into the kind of mid to deep dermis again. When we look, we do have an interface process, so the cells are extending into the epidermis, and there are scattered dyskeratotic keratinocytes and even overlying parakeratosis with vacuolar alteration along the DEJ and obscuration of the DEJ as well. Most of these cells are these small, mature-looking lymphocytes with hyperchromatic nuclei, but if you look actually at mixed amongst them, there are also these large cells that are also a little bit hyperchromatic, but they have a little bit of cytoplasm to them too as well. They're scattered plasma cells and probably some other normal here's like an eosinophil here, just like normal inflammatory cells scattered throughout as well. So this, if you, I guess, need the immunophenotype as well, this is again CD3 positive and CD4 positive, and the large cells are CD30 positive, but this is a smaller subset of the infiltrate. So this pattern is the most common subtype seen in lymphomatoid papulosis, which is type A. The differential diagnosis for this is arthropod assault and pityriasis lichenoides. Pityriasis lichenoides should lack those large atypical CD30 positive cells in the infiltrate, and given that this also has permanent interface change, arthropod assault really shouldn't have that, so that's excluded as well. So this is type A lymphomatoid papulosis. There are many different types or variants, like histologic variants of lymphomatoid papulosis. So it's always important to keep this in mind when evaluating a lymphoid infiltrate, because it can mimic a number of other lymphomatous processes. Look like a lot. So CD31 for follicular disorder, as I mentioned, anaplastic large cell lymphoma, LYP, and large cell transformation of MS. Okay. And our last case. Here we have a punch biopsy. This one has orthokeratosis overlying a slightly atrophic epidermis, but really the most prominent feature is these lymphocytes that have extended into the epidermis. So they are really liking to line up along the DEJ and extending in clusters into the epidermis. And these cells are small to medium in size. They are hyperchromatic. They have irregular nuclear contours, and many of them have this kind of vacuolar kind of artifact around them as they extend into that epidermis. So the other thing to point out is that the epidermis otherwise lacks significant spongiosis, and there is no true interface change seen as well. So there's no apoptotic keratinocytes along the basal layer. There's no vacuolar, like kind of bubbly degeneration of the basilar keratinocytes. Instead, we just have this extension of these abnormal appearing lymphocytes into the epidermis, with other features of an inflammatory process being absent in this case. So this is an example of patch stage mycosis fungoides. Other features sometimes that you could use to get you to this diagnosis are features seen in the dermis. So people will describe a wiry or homogenization of the papillary dermis, which are features of chronicity. And sometimes as the lymphocytes exit the small vessels in the papillary dermis, they like to sit on top of them. And so that's because they think it's because they're targeted towards the epidermis, so they want to sit on the top of the vessel. That's called the underbelly side. So biggest thing is just picking up on these lymphocytes in the absence of other features of an inflammatory process. This is an entity that they can easily test you on without giving you any clinical or immunophenotypic features, as you should be able to recognize these cytologic features as well. So this is patch stage MS. And there's patch, plaque, and tumor stages of mycosis fungoides. The immunophenotype can be variable, but the most common is CD3 positive, CD20 negative, CD4 positive, CD8 negative, with that ratio being greater than 4:1. CD5 can be positive or lost, CD7 can be positive or lost, and usually it's beta F1 positive and negative for the gamma delta TC receptor, and generally is CD30 negative. So that is mycosis fungoides, and that's the last case that I have for you guys. I want to thank you all for joining me tonight on this Halloween. I really appreciate you guys taking the time. And if you guys have any questions or want to give any kind of feedback, please don't hesitate to email me. My email is nbender@sagisdx.com. So I hope you guys learned something new. If you guys need anything, just let me know. Thanks.
Thanks so much, Nikki. Really appreciate it, and hope everybody has a wonderful Halloween. If you have any questions, again, please feel free to reach out and email us, and we'll see you all next time. Thank you.